Hello, and welcome to today's Journal Club hosted by the Harry Crossley Children's Nursing Development Unit. I'm your host, Fatima Ibrahim, and I welcome you to today's Journal Club discussion. I'm excited to share with you findings from an important study that directly impacts your work as pediatric nurses caring for adolescents and young adults living with HIV in Africa. Today, we'll explore research by Nguguna et al., published in the Journal of Tropical Medicine and International Health in 2020, examining what happens at adolescent and young adult HIV clinics across Kenya. So before we dive into the findings, let's establish why this research is important for our practice. Adolescents and young adults living with HIV face unique challenges that directly impact their health outcomes. They seem to have higher rates of poor medication adherence, unsuppressed viral loads, high mortality, and loss to follow-up compared to other age groups. And the 15 to 24-year age group is particularly vulnerable during healthcare transitions from pediatric to adult services. In Kenya, adolescents aged 10 to 19 years represent 7% of the 1.5 million people living with HIV and adolescents and young adults, and contributed to almost 40% of new HIV infections in 2018. So understanding how clinics are currently serving this population is essential for improving our outcomes for them. This was a comprehensive cross-sectional survey conducted as part of preparation for a larger clinical trial called ATTACH, A-T-T-A-C-H. The researchers in this study deployed mobile health teams to survey 102 public HIV clinics across Kenya. And these clinics were selected from facilities with electronic medical records and more than 300 total clients, ensuring adequate adolescent population for the study. So the survey covered 27 of Kenya's 47 counties, providing an excellent national representation and coverage. And healthcare workers with more than 6 months of experience providing adolescent and adult youth care were interviewed about clinical practices, their disclosure services, and transitional programs. The data collection process was rigorous and systematic in the study. Survey respondents first completed a paper-based questionnaire independently and then reviewed their responses with the study staff during face-to-face or telephone interviews. This dual approach helped ensure accuracy and completeness of responses. All data was then entered into REDCap, which is a secure research-based data platform commonly used in clinical research. And for analysis, the researchers used descriptive statistics to characterize clinic characteristics, models of care, and disclosure and transition services. They employed chi-square tests and t-tests to compare practices between the different types of clinic, and all statistical analysis was conducted using Stata version 14, ensuring robust and reliable results that inform evidence-based practice recommendations. Let's look at the findings. This study found that the surveyed clinics represented a diverse healthcare settings typical of most African health systems. About half were health centers or dispensaries, with the remainder being county hospitals, sub-county hospitals, and very few mission facilities. The clinic served a median of 51 adolescents and young adults each, though this varied significantly. So you'll see that some county hospitals and facilities served as many as 290 patients each, while the smaller facilities were much less, up to 59. Most clinics had a median of 15 staff members and clinical officers present in almost all of them. But interestingly, only 7 clinics had staff specifically designated for adolescent and young adult care. And even these staff were also provided for adult care, so they weren't just exclusively for this population. The study's finding also showed that despite the limited specialized staffing, these clinics had developed innovative models and approaches to serving these adolescents and young adults. So, for example, the most common strategy was designating specific clinic days for this population. So, almost 91% of the clinics had dedicated AYA days, and about 57% had remarkably scheduled these days on weekends, recognizing that adults often have school or work commitments during weekdays and so accommodated for this. Only 20% had separate physical spaces for adolescent services, showing that time-based rather than space-based solutions were more feasible. During these dedicated days, clinics offered targeted activities. They held support groups or teen clubs. They provided literacy meetings, and some offered additional services like psychosocial support, games, or career education. However, only 17% of the clinics posted extra staff during these specific days, suggesting that these services often stretched their existing resources and staff. One of the most concerning findings relates to HIV status disclosure practices. While 89% of clinics had age-based policies for when to begin disclosure discussions with these patients, there was a significant gap between this policy and actually what was practiced. In 40% of clinics, actual disclosure discussions with caregivers began a median of 2 years later than recommended by clinic policies. And similarly, disclosure discussion with children occurred 2 years later than the policy guidelines in at least 45% of the facilities. So the average age for full disclosure was reported at about 12 years of age, which is much later than Kenya's national target for full disclosure by the age of 9 to 12 years. So this delay in disclosure is particularly concerning as disclosure is a prerequisite for successful transition to adult care. Most clinics track disclosure status with 87% monitoring individual disclosure progress. Transition services reported showed both promise and challenges. Most clinics had policies specifying when transition discussions should begin, usually on average 18 years, and when they should be completed at around 20 years. However, the actual definition of successful transition were quite varied. The most common definition was demonstrating independence in one's own care, which was then reported by 78% of the clinics. But other definitions included reaching a certain age, independently collecting medication, or completing an adult clinic visit. The average age at actual transition was about 21 years of age, but this ranged widely from 14 years to 30 years across different facilities. So only about half of the clinics documented the transfer to adult services, and just over 60% tracked patients after transfer, indicating huge gaps in continuity monitoring after pediatric services. This study revealed a mixed use of available guidelines and tools. So for disclosure, almost all of the clinics use the national guidelines, and 67% use the Ministry of Health Adolescent Checklist to track disclosure progress. However, transition guidelines were less commonly used, even though they were in place. only about 69% of the clinics used them. Additionally, specialized tools were even rarer. Only less than half used disclosure readiness assessment checklists, and just 19% had transition readiness assessment tools even available. So the Ministry of Health Adolescent Package of Care checklist was being used by just over half of the clinics, representing an important foundation for standardized care. However, this tool has limited questions about transition. In fact, it just has one yes or no question about whether transition preparation discussions have begun. Seem to highlight important patterns in staffing and resources that impact care quality. So clinical officers were present in almost all of the clinics and took primary responsibility for both medical care and initiating disclosure and transition discussions. However, with an average of one clinical officer per clinic, this creates potential bottlenecks. Mental health support, for example, was particularly limited, and only 10% of the clinics had psychologists or a psychiatrist available, despite well-documented mental health challenges in this population. So the research shows that larger facilities like the county hospitals had better staff-to-patient ratios compared to the smaller facilities, potentially affecting the quality and the duration of patient interactions. And they found that task shifting some disclosure and transition responsibilities to other qualified staff members could help address workload challenges. As pediatric nurses, these findings have several important implications for practice. First, we should see that innovative resource-appropriate models of care are possible. Weekend clinic days and dedicated AYA sessions can be implemented even with existing staff. Second, the disclosure gaps highlight an urgent need for nursing advocacy and support. So we can play crucial roles in supporting families through the disclosure processes and ensuring discussions happen at appropriate ages, even before the average age. Third, the lack of mental health resources suggests pediatric nurses need enhanced training in identifying and addressing psychological needs of adolescents and young adults, especially because adolescence is such a tumultuous time with mental health. Fourth, the very transition definitions point to opportunities for nursing leadership to develop more standardized, competency-based transition protocols. So finally, the limited use of specialized tools suggests we need better implementation of existing resources, and we need to develop user-friendly assessment instruments going forward. So this article provides several important recommendations that align with nursing advocacy priorities. First, research is urgently needed on the impact of different AYA service models on the health outcomes, which approaches actually improve viral suppression, retention, and successful transition, for example. Second, there's a critical need to close the policy practice gap for disclosure through better training, using tools, and family support. And third, we need consistent transition definitions, and tracking systems must be developed and implemented. Fourth, earlier initiation of transition discussions and preparations could improve outcomes. So we really need to start at younger ages, and especially in pediatric care. The authors suggest that transition services could be integrated into existing support groups and treatment education meetings that most clinics already offer, so that they are not lost to follow-up. And finally, task shifting of disclosure and transition responsibilities to appropriately trained nursing staff could then help address workload challenges while potentially improving continuity and quality of care. As we conclude, let's see what the key take-home messages are from this important research. So firstly, innovative AYA-focused services are achievable even with limited resources. For example, weekend clinics and dedicated AYA days are working in many settings. Secondly, there are significant opportunities for nursing leadership in addressing disclosure delays and developing competency-based transition protocols. Thirdly, mental health support integration is critically needed and represents an area where pediatric nurses can make substantial impact. And lastly, the better use of existing tools and development of practical assessment instruments could improve care consistency. So this research demonstrates that with creativity and commitment, we can develop models of care that better serve adolescents and young adults living with HIV across African settings. As we wrap up, I'd like you to consider several questions relevant to your own practice context. For example, how do the AYA services in your facility compare to what was found in Kenya? And what innovative approaches could you advocate for or implement in your setting? How might you contribute to improving disclosure practices and timing of disclosure? And what role could nursing staff play in developing better transition protocols? More importantly, how can we work across facilities and countries to share the successful strategies for serving this vulnerable population? These questions can guide our ongoing professional development and quality improvement efforts. So thank you for listening today, and we hope that this reflection on adolescent and youth services can improve your practice as a pediatric nurse. Goodbye.